Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back. Keeping up with international surgical guidelines, it feels like a full-time job sometimes, doesn't it?
It really does, especially with something like acute diverticulitis. The management approach it's changed dramatically over the last decade or so.
Particularly when you look at the UK and major European surgical societies. There's been a real seismic shift.
Absolutely.
So our mission today is pretty straightforward. We want to give you the essential synthesis, a deep dive, if you will, into how these clinical approaches are converging lately.
We'll distill the current standards, the nuances around things like selective antibiotic use, standardized imaging.
And those crucial escalation pathways. Think of it as a shortcut to being completely up-to-date in your clinical decision-making.
But look, before we get into any specifics, any guidelines, we absolutely have to state this clearly. It's non-negotiable for every clinician listening.
Go ahead.
Right. This content, everything we discussed today, it synthesizes guidelines for reference and education only. That's it.
Critically important.
Your clinical practice must always adhere rigorously to your local guidelines, your specific hospital protocols, and, of course, the unique needs of each individual patient.
Couldn't agree more. Global consensus informs, but local governance dictates action. Well said.
Exactly.
Okay, so let's unpack this. The real challenge here, the tension we're managing, it's about tailoring therapy, isn't it?
It is. Moving away from those kind of protocol-driven reflexes.
Towards something more personalized, taking into account patient risk, their comorbidities.
And crucially, fitting in with these increasingly strict antimicrobial stewardship policies we all have to follow.
So tailoring therapy means accurate classification first. That's the foundation.
That's the entire foundation. You have to start with that critical distinction. Uncomplicated versus complicated diverticulitis.
Okay, define uncomplicated for us. What are we looking at?
Right. So uncomplicated means localized inflammation of the colon. Importantly, without systemic illness. So no high fevers, no tachycardia suggesting sepsis.
No peritoneal signs on exam?
Correct. No guarding, no rebound tenderness. And this is key from the imaging perspective. No radiological evidence of an abscess or perforation or any other major complication. Just thickening of the bowel wall, maybe some surrounding inflammation.
And this is where that paradigm shift really hits home, isn't it?
It really is.
Because if the diagnosis is truly uncomplicated, and we're talking about an immunocompetent adult.
Yes, those caveats are important.
The evidence now is pretty clear. Managing them without routine antibiotics is non-inferior to giving antibiotics.
It's quite a change. We're finally moving past that decades-long reflex, that immediate reach for the broad-spectrum antimicrobials.
So for these uncomplicated patients, what are the pillars of management then, if not antibiotics?
It boils down to three things, really. Good analgesia, managing their pain effectively. Adequate hydration. And critically, a structured, rapid follow-up plan.
Yep.
The goal is maximizing that antimicrobial stewardship, reducing resistance, C. diff risk, all of that, while delivering the same clinical outcomes.
That safety net, though, the follow-up plan, that's crucial. If you decide on outpatient, non-antibiotic management, what are the absolute red flags for the patient? When must they come back?
Good question. We tell them very clearly, return immediately if you develop a high-grade fever, say over 38.5 Celsius.
Right.
Or if the pain gets significantly worse, not controlled by the painkillers we gave you. Or, of course, if they develop any signs of peritonitis, like a rigid abdomen.
And if they just don't get better.
Generally, yeah. If there's no clear clinical improvement within, say, 48 to 72 hours, then we need to reevaluate. That usually means coming back in, probably getting admitted, and definitely getting cross-sectional imaging if it wasn't done up front.
Okay. So that's uncomplicated. Now, the flip side, complicated diverticulitis. This is defined by, the complications.
Exactly. Things like abscess formation, small or large, free intraperitoneal perforation where there's air or fluid loose in the abdomen.
Generalized peritonitis, or maybe more localized peritonitis.
Fistula formation, obstruction, sometimes significant bleeding. It's a whole different category.
And the pathway shifts entirely here.
Completely. And this is where CT imaging becomes absolutely paramount. It's our roadmap.
It's not just confirming the diagnosis anymore.
No, not at all. It's defining the extent, the severity, often using something like the modified Hinchy classification system. That grading is essential. It tells us if the complication needs just antibiotics, perhaps image-guided drainage, or if it requires immediate surgery.
Let's talk more about antibiotics then.
Yeah.
Section 2. Stewardship and this shift in practice.
Right. What's fascinating here is the strength of the guidance, particularly from European and UK bodies, on antimicrobial stewardship.
There's a real push.
A very strong, consistent push to proactively withhold antibiotics for that uncomplicated group we just discussed. The systemically well adults, immunocompetent, who can be safely managed at home.
And the rationale is solid.
Oh, yes. Strong data shows avoiding unnecessary exposure minimizes resistance risk, cuts down on C. diff infections, limits adverse drug effects, and importantly, it doesn't seem to increase complication rates or recurrence in that selected group.
That's still a massive cultural change for clinicians who've been practicing a while.
It is. It requires confidence in your assessment and good patient education.
Okay, but what about when antibiotics are needed? Either for uncomplicated cases where you make that call, or for complicated disease.
Right. So if you do use antibiotics for uncomplicated disease, maybe the patient is frail or has significant comorbidities or just seems a bit borderline, the guidance is clear. Use narrow-spectrum agents guided by local resistance patterns.
And keep the course short.
Exactly. Often just 3 to 5 days. And absolutely mandatory. Clear patient education on when to return, what to look for.
And for complicated diverticulitis, antibiotics are still standard there, I assume.
Oh, absolutely. They remain standard. Typically, we start broad spectrum, especially if the patient is quite unwell.
IV initially.
Usually IV, yes, particularly if they're severely ill, septic, or immunocompromised. Then the aim is always to tailor based on clinical response, any culture results if available.
And step down to oral antibiotics as soon as possible.
As soon as feasible. When they're febrile, clinically improving, and tolerating oral intake. The goal is always the shortest effective course.
You mentioned source control earlier in the context of complicated disease.
Yeah.
Can you expand on that? It's more than just antibiotics, right?
That's a really crucial point. Antibiotics are an adjunct. They aren't the whole story in complicated disease. Source control means dealing with the source of the sepsis.
So physically removing or draining the problem.
Precisely. In diverticulitis, that means either draining a collection and abscess, usually via percutaneous drainage by our interventional radiology colleagues.
If it's accessible.
If it's accessible, yes. Or it means removing the source of contamination, that is, the perforated segment of colon, which requires surgery. Antibiotics help manage the systemic effects, but they don't fix the hole or drain the pus on their own.
Right. So antibiotics support source control. They don't replace it.
Exactly. Timing is key. Get source control achieved, then use antibiotics appropriately.
Which brings us neatly to imaging and intervention pathways. Section 3.
Yes. And as we've touched on, CT of the abdomen and pelvis with IV contrast is, well, it's the undisputed standard modality in the acute setting.
It gives you that detailed map.
It does. It's not just confirming, yes, it's diverticulitis. It provides the critical anatomical detail. Where exactly is the inflammation worst? Is there an abscess? How big is it? Where is it located? Is there free air suggesting perforation? Where's the likely leak point?
So really guiding management.
Absolutely. We might reserve ultrasound or MRI for specific situations, pregnant patients, maybe young patients where radiation dose is a bigger concern, or severe contrast allergies. But for the vast majority of acute presentations, CT is the definitive standard. It lets us accurately grade the severity.
Using that modified Hinchey scale you mentioned.
Yes, or a similar validated system. It helps distinguish, say, a modified Hinchey-Ebb, a small phlegmon or tiny abscess, from a Hinchey II, a larger contained abscess, maybe distant, or Hinchey III, purulent peritonitis, or 5E, feculent peritonitis. And that grade directly impacts the treatment plan.
Okay, so that CT report comes back. It shows an abscess or a perforation. That immediately shifts things, doesn't it?
Completely shifts the patient out of that simple conservative pathway and into a more interventional, often collaborative pathway.
What are the key findings on that CT that make you pick up the phone to interventional radiology versus straight to the surgical team?
Good question. It often hinges on the abscess characteristics, primarily size and accessibility. Generally speaking, small abscesses, let's say less than 3 or 4 centimeters, might be manageable with IV antibiotics alone if the patient is systemically well and improving.
The bigger ones.
Bigger ones, or abscesses in patients who are clinically deteriorating despite antibiotics, typically require drainage. That's when we call IR for image-guided percutaneous drain placement.
And when is it an immediate surgical call?
The clearest trigger is evidence of free perforation with generalized contamination. So free air throughout the abdomen, maybe free fluid. That usually necessitates urgent surgical exploration.
Okay, let's move to Section 4. Management setting and surgical considerations. Where do we treat these patients? Outpatient versus inpatient.
Right. So for that truly uncomplicated group we discussed systemically well, immunocompetent, reliable outpatient management is often appropriate.
Focus there is on safe discharge.
Absolutely. Robust patient education on those red flags we mentioned, clear instructions, an effective but realistic pain control plan. Maybe starting with clear fluids and advancing the diet as tolerated, and that crucial close follow-up arranged.
And no needs to come in.
Inpatient management is generally reserved for those who are systemically unwell, fever, tachycardia, significant pain, or those who can't tolerate oral intake due to nausea or vomiting, or patients with significant comorbidities that make outpatient management risky, or, of course, anyone with complicated disease identified on imaging.
Management inside involves
4 fluids, 4V antibiotics, if indicated based on the complicated-uncomplicated distinction in patient factors. Daily clinical reassessment is key. Are they getting better? Worse? Staying the same? Then planning that transition back to oral antibiotics and diet, aiming for a safe discharge with a clear outpatient plan.
Now, managing complicated disease. You mentioned earlier there's some modern nuance here, especially around localized perforations.
Yes, this is a really interesting area of evolution. Traditionally, any perforation pretty much mandated surgery. That was the dogma.
Right. Air outside the bowel, operate.
Pretty much. But now there's growing experience, particularly in specialized centers, suggesting that localized perforation, what might be a modified Hinchey first or two with just a few bubbles of contained extraluminal air, without diffuse contamination, might be manageable non-operatively in highly select patients.
That sounds like a big shift. Requires a lot of confidence.
It requires extremely high clinical confidence and, crucially, the resources for very close monitoring. The patient must be hemodynamically stable, absolutely no signs of generalized peritonitis on exam.
And what does the monitoring involve?
Aggressive monitoring. Serial physical exams multiple times a day. Close tracking of vital signs, inflammatory markers, and often repeat imaging, usually another CT scan within 24 to 48 hours to confirm that the process is contained and hopefully improving or stable.
Definitely not something for every setting.
Absolutely not. This is not for the faint of heart, nor is it appropriate in low-resource settings where that immediate backup isn't available. It's a high-stakes decision.
That brings up risk stratification. We need to be good at picking out patients who seem okay but are actually high risk.
Oh.
What flags, especially in frail or elderly patients, should trigger admission, even if the CT shows apparently contained disease?
Great point. Age and frailty themselves are independent risk factors for failure of conservative management. But specific red flags. Look hard for any degree of immunosuppression, steroid use, active cancer treatment, poorly controlled diabetes. These significantly lower the threshold. Also, high fever, say over 38.5 degrees C persistently. Marked leukocytosis. And particularly in the elderly, watch for subtle signs of organ dysfunction, a rising creatinine suggesting acute kidney injury, or even slight confusion or altered mental status. These should prompt serious consideration for admission and IV therapy, almost regardless of CT findings.
And when surgery is the route for complicated but perhaps contained issues.
The guidelines generally favor the least invasive approach when it's technically feasible and safe. So if possible, a laparoscopic approach is often preferred over open surgery.
Benefits be.
Generally, faster recovery, less postoperative pain, fewer wound complications like infections or hernias. Of course, feasibility depends on the extent of inflammation, the surgeon's experience, and patient stability. Emergency surgery for diffuse peritonitis is often still done open.
Makes sense.
Yeah.
Okay, Section 5. Practical tips and long-term prevention. Let's synthesize some key takeaways for surgeons listening.
Right. First, really embrace that CT categorization. Use the modified Hinchey classification or whichever standardized system your unit uses explicitly in your documentation and handovers. It ensures everyone is on the same page regarding severity and plan management.
Good communication tool.
Absolutely. Second, constantly reinforce that antimicrobial stewardship message. Avoiding routine antibiotics in clearly uncomplicated, immunocompetent outpatients. That should be a standard quality metric now. We need to track our adherence to that.
Then third.
Upon discharge, make sure the patient leaves with an explicit, easy-to-understand set of instructions, including those red flags. Provide a realistic analgesia plan, not just take paracetamol if needed, and ensure there's a structured follow-up schedule, ideally aligned with a unit protocol, that allows for rapid reevaluation if things aren't improving as expected.
Very practical. Now, pivoting to the long term. Prevention and follow-up after an episode.
Yeah.
Lifestyle changes are key, right?
Foundational. High-fiber diet is the cornerstone recommendation. Though the evidence quality isn't perfect, it's consistently advised. good hydration, regular exercise, achieving and maintaining a healthy weight, and absolutely smoking cessation. These are beneficial for overall health anyway.
But what about surgery to prevent recurrence? When do we start talking about elective sigmoid resection?
That discussion enters the realm of shared decision-making. It's not automatic after one episode, even a complicated one sometimes.
So when is it typically considered?
Guidelines generally suggest considering elective resection for patients who have recurrent episodes of diverticulitis that significantly impact their quality of life. Or perhaps more strongly, after recovery from a complicated episode, particularly one that carried a high risk of future problems if it recurred.
What counts as a high-risk course favoring resection?
Things like an episode complicated by a fistula colovesical colovaginal. That often warrants elective resection once the acute inflammation settles. Also, multiple severe recurrences requiring hospitalization, especially in younger patients. And maybe, arguably, after successful non-operative management of a localized perforation, the risk of a future, potentially worse perforation might push towards elective surgery.
But it's always a balance.
Always a nuanced decision. You have to weigh the patient's current functional status, their age, their comorbidities, especially cardiopulmonary risks, against the potential morbidity of major colorectal surgery versus the risk and impact of future diverticulitis episodes. It's very individualized.
Okay, let's wrap up this deep dive. To summarize the key pillars from the synthesis of UK and European guidance.
I'd say three main things stand out. First, that disciplined, selective withholding of antibiotics in suitable, uncomplicated patients. That's a major shift. Second, the absolute centrality of high-quality CT imaging, not just for diagnosis, but for accurate disease grading, using scales like modified Hinchey, which then drives management.
And third,
the value of a multidisciplinary, protocol-driven approach. Getting surgeons, interventional radiologists, emergency physicians, and gastroenterologists working together within clear pathways.
that seems crucial for consistency and safety.
It really is, and maybe this raises an important question for all of us looking forward.
Go on.
Well, given this trend towards more complex non-operative management, like tackling localized perforations without immediate surgery in some cases, how does this challenge our traditional surgical training models? And what about resource allocation?
Interesting point. Are we equipping trainees and hospitals appropriately?
Exactly. Especially as we try to adhere to these evolving best practices and stewardship goals across healthcare systems with very different resources, we need to ensure we have the skills, the pathways, and the safety nets to manage patients safely, whether that's operatively or non-operatively. It's a challenge.
It definitely is. Food for thought. And as always, a final reminder. This information is based on a synthesis of current guidelines. It's intended for reference and education only.
Absolutely critical. Please ensure you strictly follow your local guidelines and protocols in your actual clinical practice. Patient safety depends on it.
Well said. And finally, if you found this deep dive useful, if it helped update your approach or spark some thoughts, please consider sharing it.
Yeah, share it with at least one colleague or friend. Help spread the knowledge.
Thanks for tuning in.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.